Okay, let's dive in. The knee, it really is a marvel of engineering, isn't it?
Absolutely. Quite remarkable if you think about it.
Handles your entire weight, absorbs huge forces, lets you run, jump, just incredible.
Complex movements.
But what happens when that key part, that sort of weight-bearing platform, gets hit so hard, well, it breaks?
Yes, that's where function meets vulnerability, really. We're talking about the very top part of your shin bone, the tibia, just underneath the knee joint. It takes the brunt.
Right. And that's our focus today, tibial plateau fractures, breaks in that crucial load-bearing surface.
Exactly.
Now, for this deep dive, we've gathered insights from some really authoritative sources. We're looking at material from the American Academy of Orthopedic Surgeons, the Orthopedic Trauma Association, Stat Pearls, OrthoBullets, top stuff.
That's right. And our aim, really, is to take all that detailed information and, distill it down. We want to help you understand what these fractures actually are, how they tend to happen, how doctors work out what's going on.
The treatment options, the recovery, the whole journey.
Precisely. So by the end, you should feel well informed about what is admittedly a pretty complex injury.
Think of it as getting the essential guide without wading through all the medical texts yourself. Let's get started then. So to really get to grips with a tibial plateau fracture, maybe a quick refresher on the knee itself. We've got the femur, the thigh bone, meeting the tibia, the shin bone.
With the patella, the kneecap, sitting out front.
Yep, and ligaments holding it steady, tendons pulling for movement. But it's that top end of the tibia, the proximal tibia, that's key here, isn't it?
It really is. That upper part of the shin bone flares out, widens quite significantly to create this surface, the plateau. That's what connects or articulates with the rounded ends of the femur above it.
Femoral condyles.
Exactly. And when we talk about a tibial plateau fracture specifically, we mean a break that involves that articular surface, that weight-bearing platform. It's a specific type of proximal tibia fracture.
And the sources make it quite clear these aren't always simple, neat breaks.
Oh, far from it. You can get various patterns. It might be a relatively clean split, or the bone could shatter into multiple fragments, what we call a comminuted fracture.
Right.
But the defining feature, what makes it a true tibial plateau fracture, is that the break extends into the knee joint itself. It disrupts that smooth cartilage surface where the bones meet. These are intra-articular fractures.
And critically, something the sources really hammer home, this isn't just about the bone.
No, absolutely not. The amount of force needed to cause this kind of fracture often means there's damage to the surrounding soft tissues as well. It's very common.
Like what sort of things?
Well, the skin itself, muscles, important nerves, and blood vessels that run nearby, and crucially, the ligaments that provide stability, like the collaterals and cruciates.
And the menisci, those cartilage shock absorbers.
Exactly, the menisci too. They can be torn or damaged. So any effective treatment plan has to consider and manage both the bone injury and all these associated soft tissue problems. It's a package deal, really.
And another key distinction is open versus closed fractures. That sounds like it complicates things further.
It adds a significant layer of complexity, yes. A closed fracture means the skin over the break is intact. Simple enough.
Okay.
But an open fracture, well, that means either a piece of bone has actually pierced the skin, or there's a wound that goes all the way down to the broken bone.
Which means a risk of infection.
A much higher risk, yes. It's a direct route for bacteria into the fracture site. Open fractures also generally mean more severe underlying soft tissue damage to start with, which often leads to longer healing times and, well, more potential complications down the road.
Okay, so it's the bone plus everything around it. That gives us a good picture of the injury itself. Now, let's shift to how these actually happen. What sort of forces are we talking about?
Well, it's possible to get minor stress fractures, or breaks, if the bone is already weakened by something like, say, a tumor or an infection. But the vast majority, the ones we're really focusing on, result from significant sudden trauma.
High-energy trauma is a term often used, especially for younger people.
That's right. The sources point out that in younger, healthier individuals, these fractures typically come from high-energy events. Think about falls from a significant height, major sports injuries, skiing accidents are a classic example, or quite commonly, motor vehicle collisions. Huge forces going through the knee very suddenly.
But it's a different story for older people, isn't it?
It is, yes. As people get older, bone quality can decline, especially with conditions like osteoporosis. So for older individuals, particularly women over, say, 70, These fractures can happen from surprisingly low energy incidents.
Like just a simple fall.
Exactly. A fall from standing height, something that might just cause a bruise in someone younger, can unfortunately be enough to fracture the weaker bone of the tibial plateau in an older person, sometimes called insufficiency fractures.
So it's that interplay between the force applied and the bone's underlying strength. Can you walk us through the mechanics, what's actually happening inside the joint during the impact?
Certainly. The classic mechanism often involves a force hitting the knee while the foot is planted. This usually combines a sideways force, either a valgus force pushing the knee inwards,
Like getting hit on the outside of the knee?
precisely, or a varus force pushing the knee outwards, hitting the inside. That sideways load is often combined with an axial load, a force compressing down the length of the bone, like landing heavily from a jump or fall.
And that combination of forces, what does it do to the bone structure?
This is where you sometimes hear the die punch analogy. The harder lower end of the femur, the die, is driven forcefully into the softer, more spongy cancellous bone that makes up the bulk of the tibial plateau, the material being punched.
Right, the cancellous bone isn't as dense.
No, it has that sort of honeycomb structure. It's good for shock absorption up to a point, but when it's overloaded like this, it compresses and can essentially collapse downwards.
And that depression can stay there?
It often does, yes. This compression and depression of the articular surface is a really common feature. Imagine stamping hard on a piece of foam. It leaves an indentation. That uneven surface is a major problem for joint function later on.
And does the direction of that sideways force determine where on the plateau the break happens?
It absolutely does. There's a strong correlation. Fractures on the lateral side, the outside of the plateau, are the most common, maybe 70–80% of cases. They're typically caused by that valgus load pushing the knee inwards.
It's in the medial side, the inner side.
Medial plateau fractures are less frequent, perhaps 10–20%. But interestingly, they tend to require significantly more force to occur. Usually a varus load, pushing the knee out, often with a high axial compression force as well. That's why you see them more often with those really high energy events, falls from height, serious road traffic accidents.
And both sides break.
Those are bicondylar fractures involving both plateaus. They make up maybe 10–30% and are also typically high energy injuries, often with a lot of compression. Understanding these patterns based on the mechanism is really key for the surgeon.
It's fascinating how the physics maps so directly onto the injury pattern. Okay, stepping back a bit, who tends to get these fractures? Is there a typical profile?
Well, looking at the epidemiology, the overall numbers show they account for perhaps 1–2% of all fractures. So not the most common break, but certainly not rare either. The incidence is around 10 per 100,000 people per year, roughly.
Okay, so seen fairly regularly in orthopedic clinics.
Oh, definitely. What's particularly interesting, though, and highlighted in the sources, is what's called a bimodal distribution.
Meaning two main groups.
Exactly. There are two distinct age groups where these fractures peak.
Who are they?
The first peak is in younger men, typically under 50. And as we've discussed in this group, it's usually down to those high-energy mechanisms, sports, falls, accidents. And importantly, these often come with more complex fracture patterns and a higher chance of associated soft tissue injuries, ligament tears, meniscus damage.
Right, and the second peak.
The second peak is in older women, generally over the age of 70. And here the cause is often those lower energy falls, perhaps just slipping over from standing height. This is frequently linked to poorer bone quality osteoporosis, making the bone fragile, hence the term fragility or insufficiency fracture.
So the same basic injury location, but often very different underlying causes depending on age and bone health. The sources also mention men get them more often overall.
That's correct. Although older women are susceptible to the low energy type, the higher frequency of high energy trauma in younger and middle-aged men means that across the whole population, men sustain these fractures somewhat more commonly than women. It really highlights how important the patient's age and activity level are in understanding the context of the injury.
It certainly does. Okay, let's dig a bit deeper now into the anatomy and that associated damage you mentioned earlier. Beyond the actual break in the bone, what other crucial structures nearby are often caught in the crossfire?
This is where the real complexity lies.
Yeah.
And it has huge implications for treatment and, frankly, for the long-term outcome.
Oh.
The knee is such a compact joint. Loads of important structures packed tightly together. A forceful fracture like this rarely happens in complete isolation.
Right.
The sources give some pretty telling figures on how often other things are injured.
You mentioned ligaments and menisci. How common are tears there?
Very common. Meniscal tears often go hand in hand with these fractures. Interestingly, tears of the lateral meniscus, the one on the outside, seem to be reported more frequently overall. They're particularly associated with certain fracture patterns, like the Schatzker type 2, that's a split with depression,
Mhm.
especially if the joint surface is pushed down significantly, say more than 10 millimeters, or if the bone widens out more than about 6 millimeters.
Mhm.
However, tears of the medial meniscus on the inner side are most commonly seen with Schatzker type 4 fractures, those high-energy medial-sided breaks. Knowing these associations helps surgeons anticipate what else they might find.
And what about the major stabilizing ligaments like the ACL?
ACL injuries aren't uncommon either, especially the more severe fracture patterns. They're reported in perhaps a quarter of Schatzker type 4 and type 5 fractures. The collateral ligaments, the MCL on the inside, LCL on the outside, can also be torn. A key thing the doctor checks during the examination is stability. If the knee gaps open more than about 10 degrees when they apply sideways stress.
Varus or valgus stress testing.
Exactly. That strongly suggests a significant tear in the collateral ligament on the opposite side to the force.
So collateral damage is pretty much expected. What about the really critical things, nerves and blood vessels?
That's a major concern because of where they run. The main artery supplying the lower leg, the popliteal artery, passes right behind the knee joint before it branches. It's quite vulnerable, especially in high-energy injuries, fracture dislocations. Schatzker type 4 is specifically mentioned as high risk for vascular injury and really any severe proximal tibial fracture.
And damage there is obviously serious.
Extremely serious. It can cut off the blood supply to the whole lower leg and foot. It's a limb-threatening emergency.
How do doctors check for that?
Well, a vital part of the initial assessment is feeling for pulses in the foot and comparing the injured leg to the uninjured one. If there's any doubt, any coolness or pallor in the foot, or if the pulses feel weak or different, they'll measure something called the ankle brachial index, or ABI.
What's that?
It's a simple bedside test comparing blood pressure readings at the ankle with those in the arm. A ratio below 0.9 is a real red flag. It suggests reduced blood flow and usually triggers an urgent investigation, typically an arteriogram and X-ray study with dye, to directly look for any blockage or tear in the artery.
And nerves, which are most vulnerable.
The most commonly injured nerve is the common peroneal nerve. It winds around the neck of the fibula, the smaller bone on the outside of the leg, very close to the top of the tibia.
Right, it's quite exposed there.
It is. So it's prone to being stretched or compressed when the tibial plateau fractures nearby. Injury to this nerve typically causes weakness and lifting what's called foot drop and numbness, or tingling down the outside of the lower leg and onto the top of the foot. The tibial nerve, which runs deeper alongside the artery, can also be injured, but it's less common than peroneal nerve damage.
And all this potential for bleeding and swelling brings up another really serious complication you mentioned.
Yes, absolutely. Compartment syndrome. This is one of the things surgeons worry about most in the immediate aftermath.
Can you explain that again?
Sure. The muscles in your lower leg are grouped into compartments, wrapped in tough, inelastic layers of tissue called fascia. When you have a major fracture, there's bleeding and swelling inside these compartments. Because the fascia doesn't stretch, the pressure inside the compartment can build up rapidly.
And that pressure cuts off blood flow.
Exactly. It squeezes the blood vessels and nerves running within that compartment. If the pressure gets too high for too long, it can starve the muscles of oxygen, leading to permanent damage, and the worst case, potentially requiring amputation if it's not diagnosed and treated extremely quickly.
The sources call it an orthopedic emergency.
Without a doubt. It needs immediate surgery of fasciotomy. That involves making long incisions through the skin and fascia of the affected compartments to release the pressure immediately. Risk factors include those high-energy Schatzker the fib fractures, having a fibular fracture as well, the sheer extent of the tibial fracture, and being younger, as younger people tend to have tighter fascial compartments. It's something that needs constant vigilance in the hours and days after the injury.
It's truly striking how one break can potentially trigger problems with ligaments, menisci, vessels, nerves, and muscle compartments. It's a whole cascade. You also mentioned a slightly different way of classifying fractures, particularly for surgery.
Yes, especially for complex fractures, or ones involving the back part of the plateau, surgeons often find the three-column concept useful. Instead of just thinking medial and lateral, it divides the plateau into three columns: medial, lateral, and posterior.
Why is that helpful?
Well, the standard Schatzker classification doesn't always fully describe fractures that extend significantly to the back. the posterior aspect. Recognizing if that posterior column is involved is crucial for planning surgery, deciding where incisions need to go and where plates and screws must be placed to properly buttress and support the entire reconstructed joint surface. It helps ensure you don't miss fixing a key part of the fracture.
Okay, that makes sense for surgical planning. So, with all of that potentially going on inside, what would someone actually feel if they sustained this injury? What are the immediate signs and symptoms they'd experience?
Well, if you were unfortunate enough to have this happen, the first and most overwhelming symptom would be severe pain around the knee.
Especially trying to stand on it.
Oh, absolutely. Putting any weight on that leg would likely be impossible due to the pain. You'd also notice quite dramatic swelling developing rapidly around the knee joint. And that swelling, combined with the pain and the actual disruption of the joint, would make it very difficult, if not impossible, to bend or straighten your knee. Your range of motion would be severely limited.
And could it look obviously wrong?
Yes, in displaced fractures, there might be a visible deformity. The knee or leg might look out of place or angled incorrectly.
And given those risks to blood supply and nerves, are there specific feelings related to those?
There can be, yes. You might notice your foot feels cold, looks pale, or maybe a bit bluish compared to the other side. That's a very worrying sign suggesting blood flow might be compromised.
Needs checking urgently.
Immediately. You might also feel numbness, tingling, or that pins and needles sensation in your foot or lower leg. That could indicate direct nerve damage from the impact, or, and this is critical, could be an early sign of rising pressure in the compartments, heralding compartment syndrome.
So these aren't just symptoms of a break, they're potential warning signs for limb-threatening problems.
Exactly. The sources really stress this. If you have an injury and experience these kinds of symptoms, severe pain, swelling, deformity, inability to bear weight, changes in foot color or sensation, you need emergency medical evaluation straight away. Prompt assessment is key.
Okay, so you've had the injury, you've got these symptoms, you're in A&E. How do the doctors systematically work out what's wrong and how bad it is? What's the diagnostic pathway?
It starts, as always, with listening to the story, taking a detailed medical history. The doctor needs to know exactly how it happened. The mechanism of injury is vital. Was it a fall? From what height? A twisting injury? A direct blow? Speed involved in an accident?
Only detailed.
Yes. And they'll ask about the symptoms you're experiencing, how quickly they came on. They also need to know about your general health, any conditions like diabetes, osteoporosis, circulation problems, smoking history, as these can all influence treatment and healing.
Then comes the physical examination. What are they looking for?
They'll perform a careful physical exam. First, inspecting the skin meticulously, any cuts, grazes, or obvious wounds that might indicate an open fracture. They'll assess the amount of swelling and bruising. Then, crucially, they check the neurovascular status of the foot, feeling for pulses, checking sensation, asking you to wiggle your toes to assess motor nerve function.
Checking for compartment syndrome, too.
Yes, they'll gently palpate or feel the muscle compartments in the lower leg. They're checking for excessive firmness or tenderness, that feeling of being rock hard under pressure, which can indicate compartment syndrome. They will also, if pain allows, gently assess the knee's stability by applying those varus and valgus stresses to check for ligament laxity, though this can be difficult in the acute painful stage.
And then imaging must be key.
Absolutely fundamental. Imaging is how you confirm the diagnosis and define the injury. The first step is usually standard x-rays of the knee. They'll take views from the front, AP, the side, lateral, and often some angled or specific plateau views to try and get the best look at the joint surface.
What do x-rays show?
They're good for showing if there is a fracture, giving a general idea of the pattern. Is it split, depressed, both its location and the overall alignment of the bones?
But you mentioned earlier x-rays aren't foolproof for this injury.
No, and that's a really important point the sources make. X-rays can actually miss a surprising number of tibial plateau fractures. Sensitivity is maybe around 85%, so up to 15% might not be obvious, especially if they're minimally displaced or mainly involve compression of that spongy bone without a clear fracture line. Sometimes subtle signs like faint dense lines called sclerotic bands or tiny alignment shifts might be the only clue on an X-ray.
So if the x-ray isn't clear or if the injury seems worse than the x-ray suggests?
That's where CT scans become essential. A CT scan gives a much more detailed picture. It provides cross-sectional images, allowing for 3D reconstruction. It's invaluable for seeing the true extent of the fracture, how many fragments there are, comminution, precisely measuring any depression of the joint surface, and clearly mapping out all the fracture lines, including those tricky posterior ones.
Critical for planning surgery, I imagine.
Absolutely essential. Surgeons rely heavily on CT scans to understand the fracture personality and plan their approach, where to make incisions, what type of fixation to use. The sources also note that seeing fat and blood mixed in the joint fluid on a CT scan lipohemarthrosis is a strong secondary sign of an intra-articular fracture, even if the break itself was subtle on X-ray. A CT can really change the game in terms of classification and treatment compared to just looking at the X-rays.
What about MRI scans? When do they come in?
MRIs aren't usually the first port of call for looking at the bone break itself. Their strength lies in visualizing soft tissues. So, if there's clinical suspicion of significant ligament damage, ACL, PCL, collaterals, or meniscal tears, an MRI is the best way to assess those. It can also pick up occult fractures, ones missed on X-ray, by showing bone bruising or edema in the bone marrow around the fracture site. So MRI is more for the associated soft tissue injuries or when there is high suspicion despite negative X-rays.
It's quite a detailed investigation process. And once all that info is gathered, doctors use classification systems you mentioned.
Yes, classification systems are really helpful. They provide a common language for doctors to describe the fracture pattern. This aids communication, helps guide treatment choices, and gives some idea about the likely prognosis. The most widely used one is the Schatzker classification.
Schatzker 5 to 6.
That's the one. It categorizes fractures into 6 types, generally increasing in severity and complexity from type I, a simple split on the lateral side, up to type 6, where the top part of the tibia is completely disconnected from the main shaft, often with severe comminution. It's a very useful system, though the sources do acknowledge that maybe 10% of fractures don't fit neatly into one of the Schatzker boxes.
Are there other systems?
Yes, others exist. The whole and more classification focuses more on fracture dislocations and instability. And as we discussed earlier, the 3-column concept is gaining traction, particularly for understanding posterior involvement and planning fixation strategies.
Okay, so the diagnosis is confirmed, the fracture is classified. How is the decision made on the best course of treatment?
This is really where everything comes together. And the sources emphasize it should be a shared decision between the patient, their family perhaps, and the orthopedic team. There's no single right answer for everyone.
It depends on the fracture.
Yes, the specific fracture characteristics are crucial. The pattern, how much the fragments have moved, displacement, whether the joint surface is significantly sunken, depression, the stability of the knee, the condition of the soft tissues.
And the patient.
And absolutely the patient. Their age, their general health, their activity level, what their expectations are for recovery, and whether they have other medical issues that might make surgery particularly risky. The overall goal is always the same, though. Restore function as much as possible and minimize the risk of long-term problems like pain or arthritis.
Definitely not one size fits all. I assume some situations require immediate emergency treatment before deciding on the final plan.
Absolutely. We've touched on these. If it's an open fracture, urgent surgical cleaning, irrigation, and debridement is needed to minimize infection risk. That's paramount.
Right.
If the soft tissues around the knee are severely damaged, massive swelling, blistering, significant bruising, maybe compromised skin, then doing a big operation immediately to fix the bone might be too dangerous for those tissues. It could lead to wound breakdown or infection.
So what's done then?
In those cases, a temporary external fixator is often the first step. Pins are placed in the bone above and below the knee and connected to an external frame. This holds the bones roughly in place, provides stability, takes tension off the soft tissues, and allows the swelling to settle and the skin condition to improve. It buys time for definitive surgery later when it's safer. That's the staged approach.
And compartment syndrome.
That needs immediate action, as we said. Urgent fasciotomy to release the pressure, no delay. Those wounds might be left open initially and dealt with later, possibly needing skin grafts.
Okay, those are the critical early interventions. What about non-surgical treatment as the definitive plan? When is that chosen?
Non-surgical management is usually reserved for fractures that are minimally displaced. The pieces are still very close to their proper position. It might also be suitable for very low-energy injuries that are proven to be stable when the knee is stressed, or perhaps for patients who weren't walking much anyway before the injury, or those with very significant health problems where the risks of anesthesia and surgery outweigh the potential benefits.
And how does non-surgical treatment work in practice?
It typically involves immobilization, maybe initially in a cast, but more often using a hinged knee brace. This provides support but can often be adjusted to allow controlled, protected movement within certain limits as healing progresses. But the absolute cornerstone of non-surgical treatment, just like after surgery, is strict avoidance of weight bearing initially.
Still need crutches or a walker.
Definitely. crutches, a walker, sometimes even a wheelchair. Putting weight on the leg too early risks pushing the fragments out of place. Regular follow-up x-rays are essential to monitor the fracture position and check healing is progressing. It's a slow process. You're likely looking at 3 months or more before you can safely bear full weight, and that's only started gradually when the x-rays show sufficient healing.
So even without an operation, it's a long haul with significant limitations. When is surgery generally the preferred route?
Surgery is typically recommended when non-surgical treatment is unlikely to give a good functional result. Key indications include significant depression of the articular surface. The joint surface being pushed down more than maybe 5 to 10 millimeters is common guideline, or if the top of the tibia has widened out by more than about 5 millimeters.
Instability is another trigger.
Yes, if the knee is unstable, showing more than 10 degrees of gapping on stress testing, that usually requires surgical stabilization. Also, fractures involving the medial side, Schatzker the fourth, or both sides, Schatzker fifth and fourth, are almost always treated surgically because they are inherently unstable and associated with higher energy.
And the timing of that surgery can vary. Acute versus staged?
That's right. If it's a lower energy fracture and the soft tissues are in good condition with minimal swelling, the definitive surgery, usually open reduction and internal fixation, or ORIF, might be done relatively acutely within a few days. But for high-energy injuries with lots of swelling, blistering, or in patients with multiple injuries, polytrauma, the staged approach is often safer. Temporary external fixation first, then delayed ORIF maybe 1 to 3 weeks later once the soft tissues have recovered. That's damage control.
Let's break down ORIF. What does that actually involve?
ORIF is the workhorse operation for many of these fractures. Open reduction means the surgeon makes an incision to directly see the fracture fragment and physically manipulate them back into their correct anatomical position, like putting jigsaw puzzle pieces back together. Internal fixation means using implants, metal plates, and screws, usually placed directly onto the bone, to hold those reduced fragments securely while they heal.
And if the joint surface was pushed down, how is that fixed?
That's a critical step for depressed fractures. The surgeon has to carefully elevate those sunken fragments of the articular surface, lifting them back up to restore the smooth joint line. But doing that leaves a gap, a void, underneath where the bone was crushed.
Needs filling.
Yes, that void must be filled with something to support the elevated fragments and stop them collapsing back down. This is often done using bone graft, either taken from the patient's own body, like the pelvis, that's autograft, or donor bone from a bone bank, allograft, or sometimes synthetic bone graft substitutes or cements, like calcium phosphate cement, which provides structural support.
Does the surgical approach where the incision is made matter?
Very much so. The choice of approach depends entirely on the fracture pattern. A lateral incision for lateral plateau fractures, a medial or posteromedial incision for those sides. Sometimes dual incisions are needed for bicondylar fractures involving both sides. The goals are always accurate reduction, stable fixation, restoring alignment, but also doing so with minimal additional damage to the surrounding soft tissues. Avoiding certain incisions is also important if a future knee replacement might be needed.
You mentioned external fixation sometimes being used as the final treatment too.
Yes, in very specific severe cases. Perhaps extremely comminuted fractures where there are just too many tiny fragments to piece back together reliably with plates and screws, or in cases of severe contamination from an open fracture. In these situations, the external fixator might be the definitive fixation. Pins go into the bone, sometimes fine wires are tensioned across the joint to support the articular surface, all connected to that external frame.
What are the downsides?
It provides stability and allows wound access, but the sources suggest it carries a higher risk of malunion, the bone healing in a slightly imperfect position compared to ORIF. Patients usually wear the fixator for quite a while, maybe 2 to 4 months.
And that staged approach, X-fix first, then ORIF it.
Yes, the bridging external fixator as a temporary measure. Pins well above and below the knee, pulling traction across the joint, ligamentaxis, can help pull the main fragments towards a better position while the soft tissues recover. It's great for managing soft tissue problems and reducing infection risk before the main surgery, but the trade-off noted in the sources can sometimes be increased knee stiffness afterwards due to the prolonged period before definitive fixation and mobilization can start.
Are there less invasive surgical options?
For certain, less complex fracture patterns, often the Schatzker 2 or 3 type surgeons, might use arthroscopically assisted techniques. Using a camera, arthroscope, and small instruments through keyhole incisions allows them to see inside the joint, help line up the fragments, and potentially place screws or even plates with less disruption to the overlying muscles and skin compared to a large open incision.
And finally, total knee replacement as the primary treatment. That sounds like a big step for a fracture.
It is, and it's reserved for quite specific situations. Mainly considered for older patients, perhaps over 65, especially if they have significant osteoporosis making the bone very fragile, or if the fracture is so severely smashed and depressed that trying to reconstruct the natural joint surface is deemed likely to fail.
What's the thinking behind that?
The rationale, supported by some evidence, is that for this particular group, going straight to a total knee replacement, TKA, might allow for earlier weight bearing, potentially a more predictable recovery, and possibly better long-term function with fewer complications compared to attempting a complex ORFF that might fail or lead to severe arthritis, requiring a TKA down the line anyway. Performing a TKA after a previous failed ORF can be technically more difficult, but it's a complex decision with its own risks.
It's certainly clear that treatment is incredibly tailored. Once that initial phase surgery or non-surgical stabilization is done, the recovery journey really begins. What does that look like?
It's definitely a long road, requiring a lot of patience and hard work from the patient. Pain management is obviously key early on. Doctors will prescribe medication, potentially opioids initially, alongside NSAIDs, maybe local anesthetics. But the sources rightly emphasize using opioids cautiously and for the shortest time necessary because of the risks, aiming to switch to non-opioid options as pain allows.
And getting the knee moving again must be high priority to avoid stiffness.
Absolutely crucial. Stiffness is a major potential problem after knee injuries and surgery. Early range of motion exercises are vital. However, when you start and how much you do depends very much on the stability of the fracture fixation and the state of the soft tissues.
How is motion started?
Initially, it might be passive motion, where a physiotherapist gently moves the leg for you, or perhaps using a continuous passive motion, CPM machine, which automatically bends and straightens the knee slowly through a set range. If the fracture was very complex or the bone quality poor, starting active movement might be delayed a bit longer to protect the repair.
And the biggest hurdle for many seems to be staying off the leg.
It really is. And adhering strictly to the weight-bearing restrictions given by the surgeon is non-negotiable. It's critical to prevent the fracture shifting or the fixation failing. You will almost certainly be non-weight-bearing, NWB, or only partial weight-bearing, PWB, for a considerable time, often 3 months, sometimes longer.
Relying on aids, then.
Completely. Crutches, a walker, possibly a wheelchair for distance. A knee brace is also usually worn during this period for extra support and protection.
And you don't just guess when it's okay to put more weight through it.
No, definitely not. Progress is guided by regular follow-up x-rays to assess bone healing. Only when the surgeon sees enough evidence of healing on the x-ray will they allow you to gradually start increasing weight bearing. It's a slow, staged process. Maybe starting with just touching your toes down, then gradually increasing the load over weeks, often still using crutches for balance and support initially.
It sounds like physiotherapy is absolutely essential throughout this.
Essential is the right word. Physio is not optional if you want the best possible outcome. Your physiotherapist really becomes your coach. You have to expect significant weakness, stiffness, and probably some unsteadiness in the leg after weeks or months of limited use.
What does physio focus on?
It progresses through phases. Early on, it's about managing pain and swelling, protecting the repair, and gentle range of motion. As healing allows and weight-bearing starts, the focus shifts to rebuilding strength in the quadriceps, hamstrings, and calf muscles, improving balance, and gradually restoring a normal walking pattern. Commitment to the exercises, both in sessions and at home, is vital. And the sources also remind us that lifestyle factors matter. Quitting smoking, for instance, significantly improves bone healing.
Can you outline those rehab phases briefly?
Broadly speaking, yes. The initial phase, first few weeks, is about protection, pain swelling control, non-weight bearing, and very gentle motion exercises. Then comes a progressive phase, maybe starting around 6 weeks or when weight bearing begins. This is where the hard work ramps up. Gradual weight-bearing progression, more intensive exercises focusing on strength, like heel raises, mini squats, step-ups, and stability balance, moving from two-legged sport towards single-leg activities. Regular physio sessions, perhaps two times a week for several months, are typical here.
And the final stage?
The advanced phase aims to get you back to your desired level of function. Normal daily activities, work, possibly sports. This involves more complex strength training, full squats, lunges, maybe some agility drills, balance challenges, and sport-specific training if relevant. The key thing is that the rehab plan is always tailored to the individual, the specific injury, the surgery, their progress, and their goals. And doing the prescribed home exercises consistently is just as important as attending the physio sessions.
A demanding process, no doubt. Looking longer term, what's the typical prognosis after one of these fractures? How do people generally fare?
It varies a lot, as you'd expect. The severity of the initial fracture is probably the biggest factor. A simple split fracture generally does better than a severely comminuted one with lots of joint surface damage. Age, overall health, bone quality, and crucially, how well the patient engages with their rehab all play a part.
Is there one key factor for success?
The sources strongly suggest that restoring joint stability and achieving good alignment are probably the most critical factors predicting a good long-term outcome. High-energy fractures, sadly, tend to have poorer outcomes overall compared to low-energy ones.
Does the type of treatment influence the long view?
It can do. As mentioned, using external fixation as the definitive treatment for complex fractures, while sometimes unavoidable, seems to have a higher rate of malunion, which can compromise long-term function. Conversely, for that specific older group with poor bone, primary knee replacement might offer better outcomes than trying to fix fragile bone or dealing with failed fixation later.
What things specifically point towards a less favorable outcome down the line?
Key predictors include leftover ligament instability, having a meniscus removed, meniscectomy, or a significant alteration of the leg's overall alignment if the mechanical axis is off by more than about 5 degrees. Also, residual unevenness or steps in the joint surface, articular incongruity, strongly predicts the development of arthritis later on.
How does this translate into getting back to normal life, work, activity?
Well, the encouraging news is most people do get back to a reasonable level of function. Studies suggest maybe 70–90% return to work within about a year. However, it's quite common to have some lingering issues, perhaps some stiffness, aching, maybe some weakness or difficulty with high-impact activities. Some might need to modify their job roles. Average knee range of motion at a year might be something like 10 to 145 degrees functional, but perhaps not quite full compared to the other side.
And there is a more sobering statistic.
Yes, it's important context.
Yeah.
The sources mentioned a one-year mortality rate around 5% associated with these injuries. That sounds high, but it reflects the fact that these often occur as part of major trauma involving multiple injuries, particularly in high-energy scenarios or in frail elderly patients. It highlights the overall severity for the most badly affected individuals.
It certainly does put the potential impact into perspective. And like any major injury or surgery, complications can happen. What are some of the potential setbacks along the way?
Complications can occur early or late. Early on, after treatment, there's a risk of things shifting loss of reduction, where the bone fragments move out of place, or hardware failure, or a plate or screw breaks. This might happen in 5–30% of cases, depending on the fracture severity, bone quality, and fixation strength.
Blood clots are always a worry with leg injuries, aren't they?
Yes, deep vein thrombosis, DVT, is a definite risk. The sources quote rates around 9% with non-surgical treatment and 6% after surgery. Immobilization and the trauma itself increase the risk, so preventative measures like blood thinners are often used.
And infection after surgery.
That's a serious concern, occurring in perhaps 2–11% of surgical cases. Risk factors include being male, smoking, having underlying lung disease, more complex fracture types like bicondylar patterns, open fractures obviously, and longer operating times. And we've already discussed compartment syndrome as a critical early complication, with rates cited from 7% up to 20% in high-risk groups.
Knee stiffness seems almost inevitable to some degree.
It's very common, affecting maybe 10–25% significantly. Risk factors include older age, higher BMI, the initial fracture severity, long periods of immobilization, involvement of the tibial eminence where the ACL attaches, and having multiple injuries, polytrauma. Sometimes significant stiffness needs further treatment, like manipulation under anesthesia or even keyhole surgery to release scar tissue.
And looking further out, what are the main late problems?
The big ones are non-union, the bone simply failing to heal, thankfully rare, less than 1%, or malunion where it heals in the wrong position, crooked or rotated, occurs in maybe 2–4%. Risks include the most severe Schatzker-6 fractures, lots of comminution, or unstable fixation initially. These often need revision surgery.
And the arthritis risk.
Yes. Post-traumatic arthritis is the most common long-term consequence, developing over time in a significant proportion, maybe 25–35% of patients. It's essentially accelerated wear and tear due to the initial joint surface damage, any residual incongruity, malalignment, or instability. Having a meniscus removed also increases the risk. This arthritis can cause significant pain and limitation, and it's the main reason why some patients, perhaps 3–7%, eventually need a total knee replacement 10 or more years later. Chronic pain and altered walking patterns, sometimes even leading to ankle arthritis, are other potential late issues.
It really highlights why getting that initial treatment right and sticking with the rehab is so incredibly important.
Absolutely. And managing complications requires specific interventions, washouts and antibiotics for infection, fasciotomy for compartment syndrome, revision surgery for non-union or malunion, arthroscopic procedures for stiffness, and eventually joint replacement for severe arthritis.
So, looking ahead, how is the medical community trying to improve things for patients with these difficult injuries? What's developing in research and practice?
Well, the sources highlight a few key areas. There's a growing emphasis on patient education, making sure people really understand the injury, the likely prognosis, and why sticking with follow-up in the demanding rehab plan is so critical for their outcome.
And it takes a whole team, doesn't it?
It absolutely does. The best care comes from an interprofessional team approach. That means the orthopedic surgeons working closely with nurses, physiotherapists, occupational therapists, sometimes others too. Early specialist orthopedic input is vital, and as we've stressed repeatedly, dedicated physiotherapy is fundamental to recovery.
And what about ongoing research?
Research continues across several fronts. For instance, there are studies looking at whether some surgically treated patients can safely start weight-bearing earlier than traditional protocols allowed, which could potentially speed up recovery if proven safe for selected groups. Minimally invasive surgical techniques, like MIPO, where plates are slid under the muscle through smaller incisions, are constantly being refined to try and reduce soft tissue damage and complications. Digital health tools, apps, tele-rehab are also being explored to help guide patients through their recovery remotely.
So, even with established treatments, things are still evolving.
Definitely. There are still areas of debate, like the absolute optimal timing for surgery in complex cases with soft tissue compromise or the nuances of specific rehab protocols. The goal is always to find ways to improve function, reduce complications, and get people back to their lives more effectively.
Well, we've certainly covered a lot of ground today, digging into the sources on everything from the basic anatomy and how these fractures happen, whether high energy impacts or low energy falls to who gets them, the associated soft tissue damage, the alarming signs and symptoms, the diagnostic process using X-ray, CT, and MRI, the wide range of treatments from braces to complex ORIFF or even replacement, the long and challenging rehab journey, the factors influencing long-term outcomes, and the potential complications like stiffness and arthritis.
I think the key takeaway is that these are far more than just a broken bone near the knee. They're complex injuries to a critical joint. Getting it right involves accurate diagnosis, a very carefully considered individualized treatment plan, often highly skilled surgery, and then a huge commitment from the patient to engage fully in what is often a long rehabilitation process. While good functional recovery is possible for many, the risk of long-term issues like arthritis is real and reflects the severity of that initial joint disruption.
Understanding all those details, from the mechanics of the break itself to the importance of precise surgery and dedicated physio, really gives you a much better appreciation of this injury, whether you encounter it yourself, know someone who has, or work in a related field. And if you found this deep dive useful, we'd certainly appreciate it if you'd consider rating the show or sharing it with others who might benefit.
It leaves you wondering, though, doesn't it? With ongoing research into less invasive techniques and perhaps even earlier safe weight-bearing protocols, how might future treatment pathways evolve? Could we see significantly shorter recovery times or even better long-term joint health for people facing these challenging fractures in the years to come? It's certainly an area where innovation continues.